Welcome back to another great episode where we talk about a very important topic. It's about quality assurance in ABA and about being an educated operator. What you don't know could hurt you in the field of ABA. And there are many operators that can be very successful in other areas of the ABA operations. But when it comes to quality assurance, oftentimes the information is inaccessible, vague, unclear. And when it comes to an organization that struggles with quality assurance and compliance, whether it's provider requirements with documentation, policies, procedures, it's not because they don't care. It's really because they don't know. And it's really hard to determine the risk for those unique circumstances. So when someone will come and ask me, what's the worst case scenario that's going to happen to me if I don't know the quality assurance and compliance in that particular state with this particular payer, it's hard to make that determination based on the size of the company, the profile of the clients, which BCBAs are supervising the clients, or other factors as well. What we do know is if we're not in compliance, depending on whatever elements they are, there is a possibility of payer clawback. That dollar amount is very hard to determine. Many times we have audits in where there's a sampling size of the documentation. So it's not necessarily saying, okay, these dates of service are being audited. It's more about when those dates of service are submitted, the insurance payer may take a sampling and then make a determination if there's a pass or fail. And if there's a fail and we're not in compliance, there is a risk of payer clawbacks. It's also hard to quantify the dollar amount and say, okay, how much money will this error result in? Each payer has their own rubric, has their own determination, and it really is, in terms of the sampling size, hard to know on the onset prior to audit submission or prior to even having an audit. There can also be denials in care. So initially during that authorization, it could be denials after the fact. And there's many misconceptions in this when we talk about denials. Many times we have organizations telling quality assurance staff, myself, or the like, saying that, well, it was approved by insurance, so the likelihood of it getting denied by an audit is really unlikely. And that's really incorrect because the authorizations team and the approval team look at different elements. There is still a risk of a payer clawback. What happens if they say, listen, given the nature of the concern, we're not going to take back money, but we want to see actionable items of what your team is doing to ensure that that compliance element that you disregarded when it came to your policy and your documentation, that you actually implement it moving forward. Now, that can also mean that they may re-audit you in the future, that they want to see if that PIP, if that performance improvement plan was successfully implemented. There's always a possibility that they can do that as well. The highest level of concern would be medical fraud. Medical fraud is admitting to services that were done that weren't done actually. So whether it's the documentation that mentioned something happens and it didn't actually occur. And in general, when we think about that audit, it's very gratifying to know that audits are part of the nature of running an ABA operation. It's not because they're looking at an organization and saying, there's something shady going on, let's look at something. Now, it is a possibility that they're doing that on occasion, but that's not the general rule. A company will get audited because of different patterns of billing. There's certain gaps that they're not able to see, and there's a risk. Now, at the same time, as an ABA organization, you're not going to look at all those data patterns and say, okay, I'm going to avoid that and that and that. You can't run an ABA operation. What you could understand is, what are those triggers? What will result in those data patterns? What different elements will insurance look at when they're analyzing data and choosing which organization to audit? And from that information, let's just make sure we have compliance elements to ensure that we can justify those patterns that they may want to scrutinize a little bit more. When they identify risk, we define standards and we make our compliance procedures. Now, what does not knowing actually look like? It's reasonable items that an ABA organization can often miss. but you can't say by an audit that I didn't know. So some common examples that I often see is using EHR templates that aren't aligned with payer standards. There are a lot of different electronic health platforms that will offer standardized templates. And they'll say, okay, this is a sample of a direct care note. This is a sample of a supervision note. You're more than welcome to use it. Many organizations may choose to use it just because it's cheaper, it's more efficient, it's already there. However, if you're not certain that it's aligned to payer standards, that's not something that I would recommend or anyone would recommend using. Following billing rules. There are certain billing rules based on CMS guidelines and general standards that we often follow. However, it also goes back to clinical best practice. We need to follow billing rules, but we can't say, I didn't know that 8 consecutive hours wasn't appropriate. Even if we followed billing rules, we still need to justify it clinically. It's also billing correctly. If you're billing correctly, but the documentation doesn't support medical necessity, that's not something that you can tell a payer that you didn't know that the documentation didn't support medical necessity. Assuming that state and payer rules are aligned and are equal, there are state rules that need to be followed, there are payer rules that need to be followed. It doesn't go interchangeably. When there's contradictions, it's very hard if the state says one thing, the payer says something else, to reconcile and figure out what would be the appropriate remediation. But at the same time, recognizing that there are many authoritative bodies and figuring out how to implement your compliance procedures accordingly. Following clinical practices, following the prescribed model of that authorization would be something that you would follow just to ensure client care. We can't say we didn't know you had a minimum amount of supervision or general oversight that would be appropriate. I did mention about the concept of we got authorized, so we're fine. Getting authorized, so we're fine is not going to factor in the alignment with the actual session notes day to day. When a payer looks at a treatment plan and approves it due to medical necessity, they don't know what the actual sessions look like only during an audit. And they can reference that treatment plan that was approved and say, that was not what I had intended. It didn't justify medical necessity. Even when it comes to parents, our responsibility as an ABA provider, whether it's the ABA operator or the clinical director, they need to inform parents of the importance of what these services are. Not only that they should understand the general methodology of ABA, but they also need to understand what their obligation is to comply with the service. We can't blame the parents and say, I didn't know that we have to enforce that for parents. Now, when does it become an actual risk? They think the payer allows it, but it wasn't clinically grounded. There was some sort of a caveat there. Relying on the BCBA to handle the justification without actual oversight by a quality assurance director or someone else knowledgeable in insurance payer standard. You can't assume that the BCBAs will be knowledgeable. We didn't know it was a new rule. I've heard that several times. There's always constant emails going out. Insurance companies will often update their website or their portal if they have one. You can't just say we didn't know. If you're in contract with them, you have a relationship with them, it's your responsibility to find out. You also want to make sure that parents aren't the ones driving the bus when it comes to ABA services. You can't say, well, parents wanted it. It is your responsibility to tell parents what the service is all about. Now, at the same time, you want to factor in the parents' needs and make it a win-win, that the parents feel their needs are being met, but the funder is also seeing that the services are being used correctly. So you want to make sure that if a parent asks for something that will directly contradict a payer expectation, you don't go ahead with it and you try to find a middle ground in which the payer is satisfied and the parents are satisfied, and it ultimately does encompass the medical necessity. Where does that leave you as an ABA organization? Understanding that payers don't audit based on intention, they audit based on patterns and visibility that they're seeing. And when they see gaps that exist, even if it was unintentional, you're increasing your audit exposure. One audit usually equates to 2 or more audits. And you're creating these documentation vulnerabilities and where you're going to have a hard time justifying what occurred. And that's where you lose control. in how your services are being interpreted. It's not about providing good care. It's about understanding that everything needs to be written on paper and you have a defensible clinical justification for everything that occurs. And this is where it shows up in real life. I'll give you some examples. We have two different companies that were audited by different payers for the same issue. The first company had clear expectations in place. Their BCBs understood what qualifies as a core deficit of autism for those payers that require ASD as a primary diagnosis. They understood how to write goals that are tied into the core deficits of autism. They understood how to justify that. So when a payer pushed back on a treatment goal, they were able to justify it and say, this is core deficit, this is medical necessity, this is based on their client's needs. And that in itself was valuable to the payer. The second company took a different approach. They allowed the BCBs to write goals based on what they felt was clinically appropriate, and there was no oversight, but without defining what the payers are actually asking for. So again, how are the BCBs supposed to know? And then the audit came, and there was no foundation. So the goals were not necessarily clearly tied into the core deficits of autism. The language and how the goals were written didn't reflect that alignment, and now they're trying to justify after the fact. And at that point, it's much harder to defend because you're already exposed. The difference wasn't the care that these organizations provided, it was the system behind it. So then the question becomes, how do you actually operate in a way that's informed and defensible? And that goes into the nature of what we're discussing, how to become an educated operator. Learn from someone who's there. Work with a QA or compliance consultant. Even if it's pricey initially, it's a very cost-effective decision in the long run. Learn from real audit experiences, not just theory. Know others that have had exposure to audits and understand how they navigated it. Get those clarities on gray areas. Many organizations struggle with those gray areas, and it's important to have a system in place. Do direct research. Call payers directly. Ask. It's okay. Ask them what the documentations or expectations look like. What do they suggest the compliance codes? And what are the protocols that are supposed to be in place? Now, they may not give you straight answers, but even so, you'll get clarity on what not to do. Also, contact those state regulatory bodies for clarification. Yes, it's cumbersome. Yes, you may get bounced around till you speak to someone, but it may guide you on those certain decisions that you're not getting a straight answer. Never rely on what others are doing. Now, stay informed consistently. Subscribe to payer newsletters, industry updates. There's so much out there that focuses on quality assurance and compliance. And even though it sounds obvious, actually read those emails. This is where the updates are. They may not be in bold, they may not be in all caps, but it's there. It's something that you should look at. And then, most importantly, build those internal compliance systems. Hire staff, a quality assurance director, QA staff, a compliance officer, whatever that structure should look like. Develop permanent product. Those quality assurance checklists are valuable for every piece of documentation, whether it's session notes, reports, assessments, program books. Conduct those mock audits, those internal audits, to really make sure that your quality assurance staff are catching those errors that you've quantified in your checklist. See if your quality assurance system needs a revamp. Make sure that you review documents such as policy, medical records, spot check whatever you can. And finally, educate your team. Educate your staff on the bigger picture. Let them know what the documents represent, not just about filling it out. They should know how documentation must tie into the medical necessity, what is supposed to support it, how all the pieces tie together, and that will help them be more informed and more compliant. And when it comes to parents, set those clear expectations from the get-go. Explain what services are supposed to look like, what is required and why that matters, and also help them understand the purpose of ABA and their role as a stakeholder in the process, so we can have consistency in participation and supporting their child's progress. Now, when both staff and families are well educated, It's not just understanding what they need to do, it's why. Services will automatically be more compliant and more defensible. It's not just about the awareness, systems, and accountability. The more educated you are as an ABA operator, the more protected you are. And if you don't define your compliance systems, they'll be defined for you under an audit. Thank you so much for listening. Have a wonderful day.